Mark, I have a question for you about the inflammation that you saw. Is that, do you believe, a consequence of the damage, or it is implicated in the effectiveness of the treatment?
Actually, I think it's both, actually. It is a consequence of the therapy, but in fact, the stimulation of inflammatory response was a negative prognostic factor. And in the laboratory, what we know is that that probably is driven by a macrophage infiltration, and it's probably an M2 type macrophage. So there's a lot more to be done to try to sort that out, but and that's where I think the imaging kind of pushes us toward the preclinical models now to try to sort out the mechanism.
Yeah, thank you. Mike Larimore, UC Davis. On the sarcoma study, Mark, were those osteosarcomas, rhabdosarcomas? Did you notice any difference?
Yeah, they were soft tissue sarcomas, and we didn't have enough of them to tell whether the genomic response was dependent upon the histologic type. I forgot to mention that. We actually did look at it, but there were so few of them of any given type that we couldn't come up with any conclusions about that. But they were all soft tissue sarcomas.
I'm Jean Starkey from SensorPath Technologies. And I just wanted to point out another application of imaging that we have been trying. We've done this in mice, which is using targeted imaging to the tumor vasculature to give us a picture from where we can define specific optical margins for a PDT type of treatment. In mice, when we use optical margins of 3 millimeters rather than 2, we get most of the mice being cured. When we do 2, it's maybe a third that can become cured. And we're just moving with the people in Gainesville at the University of Florida to extend the study to dogs. And obviously, at dogs, it's going to be very, very much easier. So if you think of a centimeter tumor in a mouse, a 3 millimeter margin, you're sort of running out of mouse. But it really looks very promising so far.
Thanks for bringing that up. That's actually a very good, you're absolutely right. That's a terrific application for imaging in canine.
Yeah, I just want to add that, optical imaging is a big opportunity for this area, especially in this idea of clearing the margins surgically, because as you point out, it's very artificial in a mouse to do this kind of thing. But in a animal where there are actually implications for a surgical margin, the optical imaging could make a big difference, and it's a very legitimate, I think, important area of research. If we had a third speaker. Yes, right, yeah. What fluorophore are you using? Mm-hmm. Great. Are there any other questions? Yeah.
Derek Rachman, Johns Hopkins. I think when I'm an imager, so I look at this differently, and we've all been talking, a lot of it has been really based at looking at pharma therapies, and sort of even in your talks you were talking about in radiation treatment, how do we assess treatment or how do we figure out the mechanisms? But I think we have a lot of things we've overlooked in imaging. Clearly we started off with a talk at the beginning of the morning where we said that rodent models were not very good models for looking at metastasis, and here we have, from the imaging standpoint of looking for these micrometastases, then going and treating them, finding these, having these not just targeted drugs, but actually targeted tracers so that we can do better non-invasive staging is a huge opportunity, as well as sort of looking at, I sit here in the genomics, and we had this sort of heated discussion earlier this morning about whether does it matter what your genomics are if ultimately you have the cancer? And I think if for me, especially in a medical institution, it allows us to think about how do we actually start looking at some of these pediatric cancers? How do we develop protocols for pediatric patients? Because really our dogs are pediatric patients. They're not adult patients in a lot of ways as well. And so it's a comment, and I don't know, we have two great imagers sitting at the table here that maybe might want to discuss that a little bit.
Well, one thing that I'd like to comment on is your idea of imaging micrometastases, because I think that is, we're very much limited by the what we can detect. Physically we can see lesions that are a millimeter or so on CT scan, but we have no idea whether they're metastases or not. And the resolution of PET with FDG and current machines is on the order of 3 or 4 millimeters. And that's many logs of cells. That's hardly micrometastases. But there are a number of new machines that are specially designed to capture pretty much every event that happens. And in that case, you can really push the signal to noise to a point where you could detect clusters of 10,000 cells. In fact, it was a provocative question raised by Dr. Varmus a year or so ago. And someone responded to it and got funded to explore that very thing. So there's really potential to really get at the idea of micrometastases using, I think, PET, which is the most sensitive technique there is, but newly designed machines that are much more efficient. Of course, they're very expensive, but they're much more efficient.
Just say too that there's a lot of work going on in the area of nanotechnology as well, where you can really load a lot of isotope into a small package, and then if it does happen to go and stick to an area where there are micromets, you get great amplification of signal and noise. So I've seen a number of applications, grant applications in that area, and I think that would be an area that would be worth looking at.
Great. Okay, I think we're on to our break. Thank you.